Any buttons. Thank you. We really are partners in crime, so this is going to be an exciting time. I'm Jeanne Conry, and as I was introduced, I am president-elect for the American Congress of Obstetricians and Gynecologists. And there's something beautiful about the timing, because Michael and I have known each other for a long time. We're both Californians, and Michael is charged with leading a fabulous organization, an agency that believes in women's health. And my message for my presidential year is really all about investing in women's health. So it's a very exciting year, I think, for me to be able to partner so well with Michael this year. I also want to say thank you very much for inviting me. I've got my Ph.D. 35 years ago, and there was nothing more important than the proceedings from the National Academy of Science. I was a field biologist, so to walk out there and see Agassiz in a painting with Lincoln and see where all of this started was really very, very moving for me, so thank you. Let me see. There. It's fun because when we're president for aCOG, we have a year for a presidential agenda. My work has been about preconception and interconception care for many years, and that really is going to be something. So I look at this time before I become president as almost my sneak preview about my interests and having a chance to share some of the ideas with everybody. But this year is going to represent some very special things because of our collaboration on the National Maternal Health Initiative that I'll refer to during this. I have no conflicts of interest. What I thought I'd do was start with a reality check. You know, I'm a practicing OBGYN. I have been for 24 years. I see patients regularly, and it is becoming more and more unusual for me to see somebody who is just healthy weight at the start of her pregnancy. It's just not as common, and Michael's pictures, his graphs show that. And we have this magic time called that postpartum visit. The postpartum visit where we try to have every woman back, and it is an opportunity for us as clinicians to discuss weight and focus on change. We maybe didn't get the message through at the start of a pregnancy. Hopefully this is going to help us make changes during the pregnancy. But as Michael said, we've got before, between, beyond. We've got times to grab women and talk with them and help them understand some of the needs. So it's as much educating the public and educating the clinicians. And we all know that weigh-in is a stressor, but it's also how we do it and the conversations that we have at a scale right then and there about it. And it's very easy to help everybody share that message. When we look at well women health and interconception care, we know that about 80% of women try to conceive at least one time, and another 70% conceive another time. And 90% of pregnancies have some type of complication with them. So it's a time when we're having a lot of different types of discussions with our patient population. Now when we start talking about obesity, I actually have a program at Kaiser in Sacramento, and we are trying to get a handle on this, and somebody said, you know, this is like world peace. I don't know how we really get a handle on it. And then I think the more important comparison was to the tobacco discussions in the 1960s and 1970s. I work very closely with one of the whistleblowers on a tobacco initiative in California, and he's very moving about what he can say about industry and about behaviors. So there are a lot of things that we need to learn about ourselves and learn about how we share information. People acknowledge there is an issue, but I think when you talk one-on-one with patients, the acknowledgement doesn't really happen. Obesity is about somebody else. Pregnancy complications are about somebody else. So there's a real knowledge gap and an information gap. And there's also a judgment gap on trying to discuss and outline and present information without judgment. And I'm sure we'll hear from people about how there's an art to doing that. When we look at preconception health, there is a goal here. And as Michael has said, healthy moms, well, healthy women, healthy mothers, healthy babies. When we look at maternal mortality in the United States, we are comparable to a third world country right now. We're up there with a third world country, and that should not be. And in fact, if you look at some states in the last decade, we've seen maternal mortality triple. That's not what we should be seeing. And then if you look at the racial disparities in California, a black woman is 4 times more likely to die related to pregnancy than a white woman. There are huge racial disparities. There are many factors here. People can come up with many explanations, but certainly obesity is one large component of this, and the health of a woman before she conceives. I'm fortunate to be working with Dr. Liu on a national maternal health initiative. And what we're trying to do with that initiative is say, what are some of the concrete things that we can do? Once a woman is pregnant, once she's in labor, once we're taking care of her, what are all the safety things that we need to address? So we've got some very concrete goals that there are powerful goals across the United States over the next 5 years. But we're also saying, what can we do to get women healthy before they become pregnant? And part of that is realizing that 50% of pregnancies are surprises. 50% of the time, women are not planning on conceiving. So we have to have this discussion and step back and say, this is about women's health. This is really about helping women become very healthy at all times, and then asking them over their course of their life, what are your reproductive goals right now? When I touch a woman, when I am seeing her, no matter who I am, if I'm an internist, a family physician, I'm a neurologist, what are your reproductive goals? Because then I can help you best decide how to proceed with your immediate decisions on medical care, your long-term decisions. How can we partner? And that's a really critical goal that we're trying to achieve. And certainly all the work that everybody has done here about weight gain in pregnancy and postpartum is critical. So when I look at well women health care, I believe that we need to address a life course concept. Over the course of a woman's life, what are her goals? Because they change. And a goal at age 18 may be very different than a goal at 25 or 28. And we don't know, nor can we judge or decide for a woman what her goal is. It's a collaboration and a discussion. We have to focus on reproductive health choices. There are great resources out there. The resources for contraception have changed so much that we really are able to help women in a way that we never were. And that is really important for us to say. I was talking with somebody earlier in our own medical group. We were trying to figure out how to help women with diabetes. So we pulled the names of every woman with diabetes, got what statins and ACE inhibitors and medications she was on, found out what her hemoglobin A1C was as a reflection of her blood sugar control for the last 3 months, and sent those names to all their obstetricians and said, find out if they're using any form of contraception. And we each called the women on our list and said, what are you doing? And called them in. I put in, probably 10 IUDs over the course of the next couple of weeks. Because if you don't know what's happening, if you don't ask ahead of time, you'll never know how to take care of somebody. So we've got to focus on reproductive health choices, and I cannot stress strongly enough lifestyle choices, including exercise. So what does aCOG have to offer? We're an organization that represents 56,000 physicians, and the women, as I say, most importantly, the women that we serve. So we have that voice for our physicians, but we also want to represent what's best for women's health. We're well known for establishing quality guidelines, looking at committee opinions that take in the research and come up with what we believe are reasonable guidelines for our fellows. And then, very importantly, especially for Michael and me, we partner with the American Board of Obstetricians and Gynecologists because we're board certified, and to maintain our certification, we have to take annual tests. And part of that testing can be testing about new information and any new guidelines. So we've got some powerful tools there for educating. It's nice to set out a committee opinion, but people might not read it, so you have to have lots of different ways to touch people. And with carrots and sticks, at least one thing is being able to put it in some of our required reading. So we've got webinars, we've got meetings, we've got online choices, and we've got aCOG. And luckily, I sit on aCOG's board, so it's a very fun place to be. What are we recommending? We have outlined the Institute of Medicine's recommendations for weight gain. Every patient needs to have their BMI calculated at the start of the pregnancy. And we don't have to go with any great tools. I mean, you can Google and come up with a BI. You can have apps for people. There are a lot of choices out there, but really reinforcing that everybody has a BMI is important. And then doing goal-directed counseling, being able to discuss with women your goals, where they are, what your goals are, and help them with the choices, and identify whatever limitations there might be. It's very important for women to begin pregnancy at a healthy weight, but as we've seen for all the graphs, that's not happening. I believe that we've got a powerful tool because we have a captive audience during pregnancy and postpartum. So those are 2 times, as much as I believe we need to address world peace, and we need to be talking about this at every visit. We've got a captive audience, and we need to, as obstetricians and gynecologists, we really need to work with that captive audience, and then really focus on the message that we're getting. And we need to share with everybody that it's not just that impact about pregnancy. As Michael showed, these women are impacting the rest of their life. And I think that's something that women haven't appreciated. We see it, you know, we can look at what's happened with our patients over time. I'll give you an example. One of my patients that I saw, probably she was 22, saw her for her first pregnancy, and she gained 60 pounds over the course of the first pregnancy, lost 10 pounds, so she's 50 pounds ahead, started her second pregnancy about 2.5 years later, gained another 60 pounds. Over the course of my time with her, she'd put on 110 pounds. And lovely, tall woman, and, you know, we talked about her weight loss, talked about everything. You know, as I've shared with a lot of people, it's not education necessarily. It's how to motivate. And for her, she gave me a tip. She came in and we'd talked, and the next year she had lost her weight. I said, "What did you do? And can I share your message?" She said, "Well, I hate to say it, but I had a Kmart moment." I said, "What do you mean by a Kmart moment?" She said, "I went in to Kmart and was buying some toys for the kids. I had to get to a birthday party, so I ran in and was just going to get some toys. I went past the women's section, and I thought, oh, I'm going to try on a pair of pants." So she said she went in and she tried on elastic waistband pants and looked at herself in the mirror and said, "Oh my God, I'm 30 years old and I'm wearing elastic waistband pants. This cannot be." She went home. She bought the present, went home, and the next morning got up 15 minutes before the kids, got the treadmill out of the garage that had been there, and started walking. And over the course of a month, she started walking, got up to half an hour. The course of the next month was walking an hour a day, set a goal of running a marathon in a year for her father who had died. She joined, I think, the lymphoma team. She lost the weight. It was, you know, we'd had many discussions, but she found her motivation. So we have to help everybody find their motivation. And she's become a motivational speaker. I've actually used her for speaking events in the community because she's like every woman that we know. She gained the weight. She had good intentions. She's a mom. She got busy taking care of the kids and putting the kids first, and that's what women do. So helping women understand that by putting themselves up a notch higher is really not displacing the kids. It's really investing in their kids. I'm a real big believer on exercise being one of the messages, and I talk about frequency, intensity, and timing with every single patient because I believe that unless we measure exercise, unless we hold women accountable for exercise, we will have failed. So I believe the message has to be both. And I believe in bang for the buck. You know, as I said, I believe that one of the things that we've got to do is have some focus, because if we try to do everything, we will fail. But we pick some messages and be consistent and relentless on those messages and get those messages to everybody. And as I've said, we need to engage aCOG and get them to include the weight recommendations and on our certification exams. We can run newsletters. We can be a voice in the community. I've got a walking group of 6,000 people in the Roseville area. They don't walk every week, but we send them messages on walking, and we highlight events. I have a physician walk with groups every single Wednesday because I want them to see that physicians believe walking and exercise and healthy choices are important. We need to have champions no matter where we are, how big our medical groups are. If we're a solo practitioner, you can find one person who can be your champion. Highlight apps that we can use, and become very public about all of this. I'll share one more story, and this is from, I can't call her a patient actually, it was Olivia Ward, who was, I think 2 seasons ago in The Biggest Loser, and she and her sister were partners in losing weight. And some people say, oh, you know, I can't stand The Biggest Loser, it's highlighting the wrong things. We actually had her come last week to our medical group, not because of her weight loss in The Biggest Loser, although that gets her recognition, but she's maintained the weight for 2 years, and we wanted her to share what kind of struggle it's been and what it's taken for her to keep her weight off. And she said, you know what, I can tell people no one's going to have the good fortune I had, you know, of having somebody, you know, being on a TV program, but she said, let me tell you what I've been doing for the last 2 years. And she shared that with us, and I said, can you give me some advice? You lived your whole life trying to lose weight. What do you believe clinicians should share with our patients? And she said, increments. She said she felt she always had to go to a gym or do something to lose weight, and it was going to have to take an hour and a half of her time. She said, if somebody just helped me understand I needed to get up 10 minutes earlier every day and do it incrementally, I think that makes a difference. And I look back at my own patient who succeeded, and hers were incremental goals. So I think as clinicians, we have to remember incremental success when we're talking with our patients. And I thought I'd share my 2 prescription pads that we give to all the physicians in our medical group. One is their walking prescription, and I give this to every single patient. I put down what my expectations are, and I tell them walk because we've got 2 feet, and somebody who's got knee problems usually can walk, so I set a goal for all of them. And then I give them a prescription, every patient when she's pregnant, I give her a prescription on weight gain and some reasons for it. So I think anything that we can do to help share that information with one another and share with our patients is really what we need to do. And I really look forward this next year to being able to partner on our maternal health initiative, because I think it will be important. Thank you very much.
Well, thank you both very much for that introduction to today's workshop. We have time for questions. Your talks came in under budget. Yes. So what we would like you give the audience a chance to ask some questions. So we have a mic in the middle and a mic over there. So you just use the mic.